Good morning, dear students. Today we shall talk about the rest of the integrated management of neonatal and childhood illness, or IMNCI. In part 1 of the discussion, we talked about the introductory part, the principles and strategies under IMNCI, and also the management of sick young infant, that is birth to 2 months of age. In part 2, today we shall talk about the management of sick child, that is 2 months to 5 years of age, FIMNCI and IMNCI plus. We shall start with the management of sick child, that is age 2 months to 5 years. In a sick child, we should look for the danger signs first, and then it is followed by assessment of different symptoms. Then we go for the nutritional status and immunization status assessment, followed by potential breeding problems, that is if there is any difficulty in feeding of the baby, and at last we look for any other problems if existing. So, what are the general danger signs? We ask the mother regarding the ability of the child to breastfeed or drink depending on the age of the child. Also, if the child is vomiting everything that is he is taking, and also if the child had any convulsion, then we look for the child's status, that is whether he is lethargic or unconscious. So, we look for any convulsion, that means we ask the mother for any convulsion, if vomiting occurred, if the child is unable to drink or breastfeed, and then we look at the child status, that is if he is lethargic or unconscious. So, these are considered as the danger signs. What if the child has cough or difficulty in breathing? If the child has cough or difficulty in breathing, then we ask for how long this is happening. Then we count the breaths in 1 minute so as to detect any first breathing. So, 2 months to 12 months, that is up to 1 year of age, first breathing is considered when the rate of breathing is 50 or more every minute. And from 1 year to 5 years, first breathing is 40 or more breathing per minute. If you remember, if you are considering 0 to 2 months, that is young infant, first breathing is when the breathing is more than 60 per minute. We also look for any chest indrawing, and we look and listen for any stridor. According to that, we classify the condition. So, if any danger, general danger sign is present, or chest indrawing is present, or stridor in calm child, then it is classified as severe pneumonia or very severe disease, and in that case the baby or the child has to be referred to the hospital urgently. Before that, we give any appropriate antibiotic. If there is only first breathing but no chest indrawing, no general danger sign, this is considered as pneumonia. Here there is no need to refer the child. We give any appropriate oral antibiotic for 5 days. If there is any cough, then we soothe the throat and relieve the cough with a safe remedy. The mother is advised about when to return immediately. Otherwise, if there is not any emergency condition, the mother can return after 2 days. And if there is no sign of pneumonia or very severe disease, we consider this as no pneumonia, cough or cold. If cough is more than 30 days, refer for assessment. There may be some different reason for that. Even tuberculosis can occur. Soothe the throat and relieve the cough with safe home remedy. If a child is 6 months or older, like tulsi and everything, honey, this can be given. Advise mother when to return immediately and follow up in 5 days if the condition is not improving. Next, we look for the presence of diarrhea. So we ask the mother if the child has diarrhea. If he has diarrhea, then we ask for how long he is having the diarrhea and if there is any blood in the stool. We look, listen and feel. We look at the child's general condition, that is whether he is lethargic or unconscious, or he is restless and irritable. We look for any sunken eyes if present. When the child is offered fluid, we look for whether the child is able to drink or not, or in case he is drinking, if he is drinking eagerly, that means he is thirsty or not. Skin pinch is checked. If you remember, very slowly means it takes more than 2 seconds to go back. Slowly means it does not go back immediately, but it also does not take about 2 seconds. Otherwise, in ideal condition, it should go back immediately. So, if 2 or more of the following signs are present: the child is lethargic or unconscious, sunken eyes, not able to drink or drinking poorly, skin pinch goes back very slowly, that is 2 seconds or more. This is classified as severe dehydration. So again, if there is no other severe classification, the plan C of rehydration, that is intravenous rehydration, is done. If there is another severe classification, in that case the child has to be referred to the hospital urgently. The mother should continue breastfeeding, and on the way to the hospital, frequent sips of ORS is given. If the child is 2 years or older and then there is a cholera in your area, give antibiotic for cholera like tetracycline, etc. So just to explain, if the child has a severe dehydration with no severe classification, remember, even in that case hospitalization is done, because intravenous rehydration or parenteral rehydration cannot be done at home. So it has to be done under strict observation and under medical care. So that is why referral to hospital is also required in this case. If 2 of the following signs are present, like restless or irritable, sunken eyes, if the child is drinking eagerly, that means he is thirsty, or skin pinch goes back slowly, that is it does not go back immediately but does not take as long as 2 seconds. So this is some dehydration. Plan B of rehydration is done. If there is any severe classification, the child must be referred to the hospital, and on the way the mother should give the child ORS frequently. Breastfeeding should be continued. The follow-up should be done after 5 days if the condition is not improving. Otherwise, if there is any condition that needs immediately follow-up, the mother should be explained about that. And if none of these signs are present, so not enough signs to classify as some or severe dehydration, it is called no dehydration. So plan A of dehydration is done. Follow-up is done after 5 days. And in certain situation, the mother has to return immediately. Severe persistent diarrhea, that is dehydration present, and if there is no dehydration, that is called persistent diarrhea. If you know what is persistent diarrhea, diarrhea persisting for more than 14 days. So dehydration may be present or may be absent along with the persistent diarrhea. If dehydration is present, dehydration must be treated before referral, and then referral has to be done. If there is no dehydration, the mother should be advised on feeding the child, also to return after 5 days. If there is blood in stool, that is called the dysentery. Treat the child for 5 days with oral antibiotic and recommend for Shigella in ADA. So maybe there is Shigella which causes dysentery. If in the area Shigella is common, so the specific antibiotic must be continued and follow up should be done after 2 days. Next is fever. So we ask the mother if the temperature, body temperature was elevated. So if the child has fever or had fever in past, maybe there is a chance of malaria. So depending on the area and depending on the transmissibility of malaria, we also have to decide the management according to that. So whether the area is high risk area or a low risk area in terms of malaria incidence. Then we ask for how long the child is having fever. If it is more than 7 days, if the fever was present every day. Also, if the child had measles within last 3 months. Then we look and feel. We look for runny nose. We look for or feel for the stiff neck. Stiff neck is a sign of meningeal irritation like meningitis. What are the signs of measles? Mainly 3C, that is coryza, cough and cold. Along with that, there can be rash. So cough is there, coryza, running nose is there, red eyes, conjunctivitis can occur. Mouth ulcers is present, pus from eyes can also be present, and clouding of cornea. In high malarial risk area, we look for any general danger signs, stiff neck or bulging fontanelle. If they are present, it is classified as very severe febrile disease. We give the first dose of intramuscular quinine after making a smear or RDT. Then we give first dose of intravenous or intramuscular chloramphenicol. If not possible, give oral amoxicillin. Also, we treat the child to prevent low blood sugar, that is to avoid hypoglycemia. And also, if there is temperature, we give paracetamol and the child must be referred to hospital urgently. If there is fever by history or taking the temperature, we suspect this to be malaria. We give oral antimalarials for high malarial risk area, making a smear or rapid diagnostic test. Paracetamol is given, follow-up is to be done after 2 days, and if fever is present every day for more than 7 days, refer for assessment. So there may be some other kind of infections or other conditions giving rise to fever daily. What about low malaria risk? Same thing, if general danger signs are present, stiff neck if it is present, bulging fontanelle, we consider this to be very severe febrile disease. So classification is basically same. Here also we are giving the first IM quinine dose. Then we give first dose of intravenous or intramuscular chloramphenicol. Alternatively, any other oral antibiotic like amoxicillin can also be given. This is given TDS. Hypoglycemia is prevented, fever, for that paracetamol is given and urgent referral to hospital. Now, the next classification is malaria. There is no runny nose, no measles and no other cause of fever. So, we can suspect malaria and we can give oral antimalarials for low malarial risk area after making a smear. Paracetamol is given for fever, mother to follow after 2 days, and again if the fever is persisting daily for last 7 days, then referral should be done for further assessment. If there is runny nose present or measles present or any other cause of fever present, then fever, but it is not likely to be malaria. So paracetamol is given for fever. The mother is told to follow up after 2 days or to return immediately if necessary, and again assessment is to be done if fever persists for 7 days continuously. Now, in this regards, I would like to mention something. Now, this is the old classification and management protocol of IMNCI. I don't think there has been any change according to IMNCI, but since we are talking about malaria in this part, you have to remember after smear or RDT, if the disease or rather if malaria is diagnosed, we don't give IM quinine like that. So depending on whether this is a Vivax infection or a falciparum infection, we give the anti-malarial agent like that only. So in case of Vivax, we give chloroquine. In case of falciparum, we go for ACT-SP in our state. ACT-SP is artemisinin combination therapy. There is sulfadoxine pyrimethamine along with primaquine. Also, that is also true for malaria. Presumptive treatment is not done. That means just on the basis of the fact that a person has come from an area which is highly transmissible for malaria, we don't give him antimalarial for any case of fever like that. We go for testing. If the diagnosis is positive, only then we give the antimalarial agent. So, if there is measles or history of measles in last 3 months, then you look for any general danger sign, clouding of cornea, deep or extensive mouth ulcers, which are very common in case of measles. So, this is measles along with severe complication, severe complicated measles, and they are mostly due to vitamin A deficiency. So, first dose of vitamin A is given, first dose of injectable chloramphenicol is given. If it is not available, then we give oral amoxicillin. If clouding of cornea or pus draining from eye, that is indicating of conjunctivitis or any kind of eye infection, we give tetracycline eye ointment, and the child has to be referred to the hospital immediately. If there are mouth ulcer or pus draining from eye, this is measles with eye or mouth complication. So, this is not severe complication because danger signs are not present, clouding of cornea are not also present. So, again we give vitamin A, we give tetracycline eye ointment, and if there is mouth ulcer, it is treated with gentian violet, and the mother has to return for follow-up after 2 days. If there is measles at present or in last 3 months, then we just give vitamin A, because in case of measles there is deficiency of vitamin A, the store from liver is depleted. Then we look for the ER problems. If there is an ER problem, we ask if there is any ER pain or any discharge coming out of the ear. If yes, then for how long? Then we look and feel. We look at any pus draining from the ear. Also, we feel any tender swelling behind the ear. That can be a mastoiditis. So, tender swelling behind the ear is a mastoiditis. We give first dose of injectable chloramphenicol, if not possible amoxicillin. We give paracetamol for pain. Ideally, any other analgesics should be avoided, especially NSAIDs, and the child has to be urgently referred to the hospital. If pus is seen draining from the ear and discharge is reported for less than 14 days, or there is ear pain, it is considered as acute ear infection, maybe ASOM or something like that. So, amoxicillin is given for 5 days, paracetamol for pain. Dry the ear by ear wicking using the cotton to make the ear canal dry by absorbing the discharge, and follow up is to be done in 5 days. If the pus is seen draining from the ear and discharge is reported for 14 days or more, so same thing like this, but the duration is more than 14 days. So, this is probably CSM, so chronic ear infection. Same thing, dry the ear by wicking, topical ciprofloxacin ear drops for 2 weeks, and follow up in 5 days. If there is no ear pain, no pus seen draining from the ear, there is no ear infection, so no additional treatment is needed. Next, we look for malnutrition and anemia. What do we look and feel for? We look for visible severe wasting. We also look for palmar pallor. What is palmar pallor? How to look for palmar pallor? So take the palm of the child and look at the creases. If the palmar crease is darker than the rest of the palm, that is ideal. If the color of the creases is same or lighter than the rest of the palm, then there is definite anemia present. So that is a sign of pallor. Whether anemia is present or not, for that obviously you have to go for hemoglobin estimation. Okay. So we look for palmar pallor if it is severe pallor or some pallor. If there is edema on both feet, and determine weight for age. So we are talking about weight for age. This is the WHO growth chart. Z score. In young infant, that is 0 to 2 months, ideally this chart should be used. Even for 2 months to 5 years of age, this chart can also be used. So you can see from the x-axis the birth, 1 year, 2 year, 3 year, 4 year and 5 years. So up to 5 years this chart can cover. There are many reference lines. I am not going into details about the growth chart. I am assuming that there has been a class on growth chart and everything has already been discussed. So I am just going to tell the growth chart in very short. Ideally, okay, in x-axis we have the age, in y-axis we have the body weight in kilogram. All right. So for any particular age, you have to find out the weight of the child and plot the dot anywhere. Ideally, if the dot lies between these two red lines, or better to say +2 to -2 standard deviation, this is ideal, this is normal. Okay. In developing country like India, we are mostly bothered about the body weight or weight for age below this -2 standard line or the lower red line. So if a dot lies between this -2 and -3 standard line or standard deviation lines, that means in this area, this is mild to moderate undernutrition. And any dot below the black line, that is below the -3 standard deviation line, this is considered as severe malnutrition. Okay. So from this chart alone, we can determine the weight for age and also can interpret the finding. So this is a chart for the girls. First of all, girls is already written. Another thing is, it should always be in color pink. For boys, it should be in blue color, basically a sky blue in darker shade, but the lines are almost same and the interpretation is also same in this case. If there is visible severe wasting or edema of both feet, severe malnutrition, and we give single dose of vitamin A, because in case of malnutrition there is also depletion of vitamin A store. We prevent hypoglycemia, the child is referred to the hospital. With referral is being organized, warm the child, because malnutrition is associated with hypothermia, and keep the child warm on the way to hospital. Severely underweight, that is less than -3 standard deviation. So this is -3 standard deviation. If it lies below that, this is very low weight. Assess and counseling for feeding. If feeding problem, follow up in 5 days. So how to feed the child, what to feed the child, all these things must be told to the mother. And if there is feeding problem still persisting, the mother should follow up in 5 days. In some cases, mother should return immediately, otherwise she should follow up in 30 days. Not severely underweight, that is above -3 standard deviation. So above this black line, if it is within these two red lines, that is good, and this is mild to moderate. So not very low weight, there is low weight, but that is not very low age. If the child is less than 2 years old, assess the child feeding and counsel the mother on feeding according to the food box or counsel the mother chart. So basically the feeding pattern or feeding habit of a child depends on the age of the child. This feeding practice I will discuss it a little bit later, and advise the mother when to return immediately. Okay. Now about the anemia, we are looking for the palm, basically palmar creases and the rest of the palm. If there is severe palmar pallor, the child should be referred urgently to the hospital. If there is some pallor, iron and folic acid is done for 14 days. Assess the child's feeding and counseling, because we have to know whether the food that the child is consuming has adequate iron in it or not. So that is why the feeding pattern, also the type of food being given to the child, must be counseled about. Follow-up is to be done after 14 days, otherwise the mother should be told when to return immediately. If there is no palmar pallor, that is no anemia, and we can give prophylactic iron and folic acid in child 6 months or older. So if you know about Anemia Mukt Bharat, there is provision of iron and folic acid in tonic or syrup form for children above 6 months of age. Okay, and 6 months to 10 years there is one dose, then 10 years onwards there is adult dose. Also there is provision for women of reproductive age group as well as pregnant and lactating mothers. We should always look for immunization status, and we follow the national immunization schedule. So at birth the child must have received BCG, OPV 0 dose, hepatitis B birth dose. At 6 week OPV 1, pentavalent 1, rota 1, fractional IPV 1 and pneumococcal conjugate vaccine 1. 10 weeks OPV 2, pentavalent 2, rotavirus 2. 14 weeks OPV 3, pentavalent 3, rotavirus 3, fractional IPV and pneumococcal vaccine 2. So these two, fractional IPV and pneumococcal conjugate vaccine, they are received at 6 week and 14 week. Okay. This pneumococcal conjugate vaccine booster is received at 9 months along with measles 1, vitamin A and Japanese encephalitis 1. The same thing, that is measles 1 or measles rubella 1 and Japanese encephalitis 1, they are repeated, that is the second dose at 16 to 24 months. So measles 2, MR2 and JE2. Along with that, the DPT first booster dose along with OPV booster dose are given at 16 to 24 months. At 5 to 6 years we go for DPT, that is second booster dose. At 10 years and 16 years we go for diphtheria, toxoid and tetanus, DT. And then there are provision for pregnancy also, but since we are talking about IMNCI, we do not need this part. Okay, you have to know up to this part, 16 to 24 months for this. But for your exam purpose, you should always remember and memorize the national immunization schedule in full. Now a little bit of counseling must be done for the mother or the caretaker of the baby. So we ask and listen. That means we ask the mother or the caretaker about the problems that the child is having. Because since the mother or the caretaker is always with the child, and the child in this age group cannot tell us about the complaints. If you are talking about infants, obviously they cannot talk, they cannot even talk. So they will not say you anything. Even older childs like 3 years, 4 years or 5 years, they will not be able to express themselves completely. So they will not be able to tell you their problems in details. So that is why we ask the mother, and when we ask them, whenever they are giving response to your questions, you should always listen to them. Okay. Then praise the mother. That means all the correct practices she is following, you should always praise her, because this praise acts as the motivational factor, and she will rather continue the correct practices in future. Then you will advise about what to do. also about what not to do, and then check, because after giving advice our responsibility does not go away. We should always ask the mother to follow up, and we should check whether she is following the advices as given by you. If there is any mistake, you should always advise again or rectify that, that is feedback. What are the essential elements of counseling the mother? Regarding how to give oral drugs, how to treat local infections, how to manage breast or nipple problem which can give rise to difficulty in feeding, teach them the correct positioning and attachment for breastfeeding, counsel on other feeding problems. We should advise them when to return, that means when to follow up or when to return immediately. Counsel the mother about her own health, because if the mother is not physically fit or mentally fit, she will not be able to take care of the child. So that is why the mother's health is also very important. Now feeding recommendation, I was talking about this earlier. Up to 6 months exclusive breastfeeding is to be done, no question about that. Nothing should be given. Prelactial feed should also not be given, that means giving something before introducing the breast milk, immediately after birth. There is a custom of giving honey or something like that, which is absolutely wrong. It will introduce infection only. So exclusive breastfeeding, even after birth the mother should give colostrum, that should not be discarded. Okay. From 6 months up to 12 months, breastfeeding has to be continued. Along with that, 1 katori of serving. Okay, 1 katori, katori means in Bengali call it bati, or you can call it also a cup, something like that. So if the breastfeeding is being continued, this katori feeding should be done 3 times daily. If breastfeeding is not continued, so the deficit should be managed by giving katori feeding 5 times daily. Alright. So 3 times if breastfeeding is done, 5 times if breastfeeding is not done. From 12 months up to 2 years, breastfeeding is to be done. Food from family pot, that means whatever the family is consuming, maybe rice, dal, vegetable, fish, meat, egg, anything, little amount should also be given to the child. So this is basically introducing the child to the family diet. So food from family pot. Along with that, 1.5 katori serving 5 times daily. Alright. So ideally breastfeeding should be continued, food from family pot, and 1.5 katori. This was 1 katori, but this is 1.5 katori, because with increase in age, the demand or the need of the body is also increased. So calorie requirement is increased. That is why food, amount of food is also to be increased. 2 years and older, ideally breastfeeding can be avoided. I mean, if a mother is willing to continue breastfeed, then she definitely can, but there is no recommendation for that. Okay. So 2 years and older, family food, 3 meals each day. So breakfast, dinner and lunch, they should be done. Twice nutritious food, that means not only the quantity, also the quality has to be taken care of. Only nutritious food should be given in the forms of vegetables, fruits, etc., cereals. When we say katori serving or katori feeding, we actually mean mashed rice, roti, bread, biscuit mixed in sweet milk or in thick dal with ghee, offer banana, mango, papaya or dalia, halwa, kheer in milk. So calorie rich. So they are high calorie because, as I mentioned, this is the growing phase of the child and they need high calorie for their growth. That is why high calorie diet, also nutritious things. So when to follow up? When the mother should follow up? If the child has pneumonia, dysentery, malaria, if fever persists, malaria unlikely, Measles with eye or mouth complications, the mother should return in 2 days. In case of persistent diarrhea, acute ear infection, chronic ear infection, feeding problems, or any other illness that is not improving, she should come after 5 days. If there is very pallor, that is 14 days. In case of low weight for age, 30 days. So these are the time period after which the mother should follow up with the child. In certain cases, the mother should return immediately. For in case if any sick child is not able to drink or breastfeed, becomes sicker, that means the condition has gone worse or deteriorated, develops a fever. If the child has no pneumonia, cough or cold, also return if there is fast breathing or difficulty in breathing. So maybe initially there is no fast breathing or any difficulty in breathing, but later on fast breathing develops, maybe there is chest indrawing, etc. So in that case, she should return immediately. Also, in case of diarrhea, if there is blood in stool, that is dysentery is present, or drinking poorly, so that means oral rehydration is kind of difficult, and that will lead to further dehydration. In that case, the child should also return immediately. So what does IMNCI offer? It offers assessment and classification of all children presenting to the physician. As I mentioned in my first part of discussion, in IMCI, which is adapted by WHO and UNICEF, the first 7 days, that is early neonate, was included. So in IMNCI, all the children are included. Initiating treatment for all children, for that we go for counseling, we initiate drug treatment, pre-referral treatment, that means in case of any referral to higher center, initial dose of antibiotic or any other medicine is given. So pre-referral treatment. Also referral advice for serious conditions, like how to keep the baby warm to avoid hypothermia during the journey to the hospital. Management where referral is not possible. In certain cases, very rarely referral may not be possible. So in that situation, what can be done or what should be done, that is also covered under IMNCI. We have to remember that there are certain things IMNCI does not offer. So there is also some limitation for IMNCI. For example, in case of severe pneumonia, severe febrile illness, severe malnutrition, severe persistent diarrhea, sick young infant with sepsis, severe jaundice, so all these severe conditions, right, they are very difficult to be managed without any critical care services. So SNCU, that is sick newborn care unit, etc. may be needed, and these services do not come under IMNCI. So after a certain point of time, when the complication has developed or has already developed, the child or the baby has to be referred to higher centers where this sophisticated and improved facilities are available to treat or to manage these severe conditions, which may not be possible at basic level under IMNCI. Care at birth for all newborns. IMNCI itself does not offer any care at birth. Birth asphyxia cannot be managed, and also emergency triage treatment, that can also not be done under IMNCI. The next concept is FIMNCI, that is facility based IMNCI. So FIMNCI is an integration of the existing IMNCI package and the facility based care package into one. Okay. So here under FIMNCI, asphyxia management can be done and care of sick newborn at facility level can be done. So you can see So care of all newborns is not done. So care of sick newborn may not also be done, and birth asphyxia management was not done under IMNCI. But these two have been included in FIMNCI. Majority of the health facilities like 24/7 running PHCs or primary health centers, first referral units, community health centers also known as block primary health centers in our state West Bengal, also district hospitals. These facilities do not have trained pediatricians to provide specialized care to the referred sick newborns and children. The FIMNCI training will therefore help in skill building of the medical officers and staff nurses posted in these health facilities to provide this care. So, since in these health facilities, not all these health facilities has trained pediatricians. So, in that case, if the existing medical officers and nurses, they are trained to manage this kind of complications or severe illnesses, that will actually benefit the purpose. So, that is why the FIMNCI was introduced. So, what are the core competencies of FIMNCI? If you look at the IMNCI here and FIMNCI on the other part. So, IMNCI understand the IMNCI process and rationale to know how to use the IMNCI chart. All these color coded things I showed you, these things. So, they are basically from IMNCI chart. Now, wait a minute, sorry, yeah. So, the health personnel, the doctors, the nurses, they now know how to use the IMNCI chart, and according to that, they can classify and give the treatment. In facility based care, the care at birth was introduced. In IMNCI, there is communication with the caretaker, danger signs in the children and severe signs in the newborns and young infants are identified first. Then we look for any other complications or other conditions. Not many essential procedures which is present in facility based care, because more severe conditions are dealt with here. Malnutrition and anemia are dealt here, that is they are managed under IMNCI. Immunization status is checked, vitamin A supplementation, all these things are done. Young and infant child feeding practices is also followed in IMNCI. The same thing is also done here. Severe acute malnutrition, also known as SAM. Generally, they are severe condition and are taken care of at NRC, that is Nutritional Rehabilitation Center. So, facility based care FIMNCI can take care of this SM childs, but the SAM children cannot be taken care of at IMNCI. Alright. So, there is also provision of emergency triage and treatment. So, basically IMNCI service along with facilities as well as the competency of the medical officer and staff nurses to take care of the severe conditions, especially birth asphyxia, sick newborn at facility level, etc. The next concept is IMNCI plus. Another thing, this is basically the extension of IMNCI. So, it connotes wider comprehensive range of interlinked interventions that from the newborn and the child health component of the RMNCHA plus program. It includes skilled care at birth, IMNCI, including inpatient care and immunization. So, if we look at this, the IMNCI care is provided obviously. Along with that, facility level care, that is inpatient care, that means after admission. This is done home and community level, home based newborn care, that is also done as you can see here. Newborn and child health care. The inclusion in IMNCI plus is care at birth, which is not ideally given at IMNCI. Also immunization, that part is also covered in IMNCI plus. Okay, so with this I conclude this session. We have discussed how to manage different conditions for young infants, that is 0 to 2 months of age, as well as 2 months to 5 years of age, that is sick child. But before that you also need to know how to classify the condition. So for that we are looking for selected signs and then we classify it and also color code it, and according to color the management should be done. So what can you face during your examination? What kind of question? So they will give you certain condition, so they will give a detailed history and they will ask you to classify the condition according to IMNCI and also to give the treatment. You can see previous university exams question and you will have some idea. So anyway, if you have any doubt or query regarding today's topic, please let me know and I shall try to solve the problem. Thank you.